Hello everyone, this week we'll be talking about the immune system and focusing on immunosuppressive therapy as well. So, quick immune system review. The immune system is a fairly complicated setup, just like really anything in the body. This isn't unique to the immune system, but the immune system has a lot of different receptors and cell interaction type systems that can be manipulated by drugs. So it is a little bit unique in that sense, where there are a number of different ways we can manipulate how T cells respond to antigens. And by doing that, we can therefore suppress the response of the body's immune system, which can be beneficial in lots of different situations. This is just that same picture, but it shows you all the different drug targets that exist currently on the market. There's a number of other ones too, but that just covers some of the basics. Just to quickly review, I'm not going to spend a ton of time on this because you guys probably get this in other classes, and honestly, you've probably had this in a lot of your undergraduate work as well. But the innate immune system is our first line of defense. We have this at birth. We don't learn it. It protects us before our adaptive immunity has a chance to kick in. Anything from a physical barrier like your skin is part of the innate immune system. Things we have like enzymes, proteins, peptides that are antimicrobial naturally help us fend off certain infections. And we have cells like macrophages, mast cells, and natural killer cells, which do the same thing. So those don't need to learn any type of antigen to be effective at killing it again. Now, our adaptive immunity is our slow response. So this is our B cells and T cells. And these are going to be mobilized from cues from the innate immune system, and they're going to provide either humoral or cell-mediated immunity. Again, not going to go through a ton of information about this, but basically you have a learning system here in place, right? That your B cells can form memory remember is a loose term, right? It's not actually what's happening, but they get presented an antigen and then they can build a response against it in the future, which gives us our long-term immunities to different pathogens that we encounter throughout our life. T cells, activated by an antigen-presented cell, they secrete cytokines, they attract macrophages, and activate NK cells, so they actually have some interaction with the innate immune system as well, which is pretty cool. So why do we want to disrupt this wonderful process that keeps us safe? Well, there are a number of reasons why the immune system sometimes does things that are generally a little bit overzealous in nature. So our normal immune system is going to help neutralize toxins, inactivate viruses, destroy transformed cells that are mutated, and eliminate pathogens from our body. An abnormal immune system might cause things like hypersensitivity, which is like an anaphylactic reaction, causing lots of inflammation and possible ultimate tissue damage and organ damage, things like that. Autoimmunity is reacting against the own body. There's plenty of autoimmune diseases we'll talk about throughout the course, and I won't go into any of those right now. Immunodeficiency is impaired reactivity, and that's another thing we'll talk about here today. As far as type 1, 2, 3, 4 hypersensitivity, I don't really care these specifically, other than that I think it's maybe a little bit useful to talk about them as far as from a drug perspective, what it means. So a type 1 hypersensitivity reaction is an anaphylactic reaction. Hives also is generally considered this. So if you see on somebody's allergy list when you're prescribing medications, if you see them have anaphylaxis or reported hives, that's usually when we take the reaction a little bit more seriously than if they, just said, oh, I got a rash with amoxicillin. Well, a rash might not mean we're going to deter, it might not deter us as healthcare professionals from recommending or prescribing something in the beta-lactam class. Now, hives or anaphylaxis may and should probably, in fact, deter us from that. Type 2, IgM and IgG complexes with the foreign body. Blood transfusion reactions can happen from this. It may predispose you to certain anaphylactic reactions. We aren't really sure how. That's one hypothesis of how people get anaphylactic reactions to things, because of maybe they got a blood transfusion at one point and were exposed to something that now is making them excuse me, hypersensitive. Type 3. This is what's commonly known as like a skin or drug rash. So these usually present like 3 to 4 days after exposure. So that's one of the big differences between, you know, a drug rash versus like hives or anaphylaxis. It's going to take some time to develop. And type 4 is cell-mediated, 2 to 3 days after exposure. Something like poison ivy is a common type of type 4. Now, poison ivy versus type 3, like what exactly is the difference? It can both take kind of a similar amount of time to present, but that's why it can be hard to rule out like what's an allergic response versus what did you encounter in nature that might have caused something like this too. So there's obviously different situations here which might predispose somebody to have a type 3 or type 4, but the point is these two take a little bit more time. Autoimmunity is the failure to distinguish self tissues from foreign. So things like, again, stuff we're going to talk about later in the semester for the most part: rheumatoid arthritis, type 1 diabetes, Crohn's disease. Immunodeficiency is an inadequate function of the immune system, usually caused by either genetic diseases or things like autoimmune deficiency syndrome or AIDS. And obviously we can cause this too with drugs. So we can put people into an immunodeficient system by either giving them medications that do this or as a side effect of certain medications like chemotherapies. Just to kind of talk about some quick, interesting things out there, because we don't really have a chance to talk about this anywhere else. There's a lot of interesting immunotherapies that are kind of coming to market and being studied right now, looking at things like plasmapheresis, which is where this is actually kind of an old thing, plasmapheresis. You remove plasma and antibodies and replace with non-antigenic plasma. So you're basically just replacing the person's plasma over time, usually replacing it, giving serum, giving albumin and things like that as well at the same time. And it can help with the overall sensitivity that's going on, or the autoimmune disease potentially as well. IVIG is something that is a blood product. So they take plasma from people who donate it, and then they extract these antibodies from, or whole blood or plasma, I should say, extract the antibodies from these products, and they purify them down, and then basically a company works for this and resells it as a product. Then so things like you'll see brand names are Privigen, Carimune, Gammagard. Doesn't matter what the brand names are. That's all IVIG. And what they do is they form complexes that cause an overall anti-inflammatory effect in the body. We don't really understand the benefits, but it's used pretty broadly in a number of different diseases. So you might see that, especially if you work in more rheumatology or areas where we're working against working with manipulating the immune system. And MS is another thing that I don't really talk about anywhere else, so I just wanted to mention it really briefly. There's a lot of medications around MS. I won't test you on anything related to MS. It's really specialized, but there's different types of interferon drugs that suppress T cell activity. There's chemotherapies we might dip into for MS. There's a couple specific MS drugs that are really, really expensive that do specific things within, to prevent either cell damage or inflammation. Futuristic stuff, gene treatment's pretty cool. There's a drug called Kymriah, which is for acute lymphoblastic leukemia. So they take the patient's own T cells, harvest them, genetically modify them using a virus, and then give them back to the patient. So it costs like $500,000 to use this, but the company, if the patient doesn't get any response, they'll actually refund any fee they charge them. So it's pretty cool. I think we're going to see a lot more of this stuff going forward. It's a little bit more groundbreaking in the science behind it and the idea of shifting our focus on how we treat certain things versus, traditional chemotherapy and things like that. So more stuff to come with this for sure in the next few years, but it'll be interesting to watch how immunotherapy changes the way we treat some of these cancers and autoimmune disorders that are traditionally fairly difficult to treat. All right, we have to talk about steroids first before we get into the solid organ transplant type anti-rejection medications, because steroids are a core component of those. When we use the term steroid as far as drugs go, we're usually talking about 3 different things. And for the most part, therapeutically, steroids are going to refer to glucocorticoids. So you hear people often like, oh, let's give them some steroids. And that just means that they're usually talking about a glucocorticoid. Other steroids therapeutically that we use would be mineralocorticoids, which have more effects on salt and water balance, and then the sex hormones too, like androgen, estrogen, progesterone type analogs there. So we'll talk about these more with respect to men's and women health specific modules. Mineralocorticoids don't have a ton of therapeutic benefits. We'll talk about them briefly. Glucocorticoids are going to be the big thing we talk about in this lecture. This messy structure map is just showing that all different steroids kind of have the same chain and look really similar. I actually had a test in pharmacy school in my medicinal chemistry course series where I had to match these to their actual drug name, which I know sounds ridiculous. Like, why would you ever make somebody know that? But that was just the way they did it, I guess, in that class. But anyway, cholesterol is exactly what you think of it as cholesterol, and that's the precursor to all steroids. And so we make different types, and you can see they're kind of broken down. So these are progestins, and then androgens, and then estrogens are made from androgens. And then you have other things too, like aldosterone, corticosterone, and cortisol. Cortisol being the body's primary stress response hormone, has to do a lot with suppressing inflammation and also the immune system, and just how it works with that. And that's usually when we talk about glucocorticoids and steroid use in medicine, we're talking about basically mimicking the form of the function of cortisone via drugs. So glucocorticoids, again, I just talked about cortisol. It's our major endogenous hormone. More stress, higher amounts. It does things like increase blood glucose, enhance glucose uptake, curbs some non-essential functions that you don't need during a stress response. This talks about long-term versus short-term stress response. People who get short-term bursts of cortisol, there's very little that's going to impact them adversely. You're going to get some increases in blood glucose, blood pressure, breathing rate, but that's going to last it's going to be very short-term, like it says here, and it's going to leave the system pretty quickly. You aren't going to get sustained enough effects to be problematic. Now, if your body's constantly undergoing stress, like not necessarily you always, I mean, it could be like this if you always feel really stressed out at work or you have a really high stress job. Certainly you could have kind of a chronic long-term response like this going, but also some disease states will put people into a long-term stress response, such as like heart failure is a big one, where over time, just the way that the heart can't pump, your body compensates for that. And one of the ways it does that is to release more cortisol, which has fluid imbalances, blood pressure problems, and ultimately it's the body's way to compensate, but over time it actually does more damage than good. So again, our glucocorticoids, people call them steroids or corticosteroids. They have a lot of different applications. We'll come back to them multiple times. I'll kind of throw them out there to see like, oh, they use prednisone for this, or you can give steroids in this situation, etc. They mostly affect cellular immunity. And there is actually a hormone, a glucocorticoid receptor in specific immune cells, and the steroid will complex with them, and it ultimately causes a downstream effect that prevents some inflammatory processes from happening. Now, because this is interfering with some natural things in the body, there are adverse effects that we'll talk about, but overall, this is promoting an anti-inflammatory response. You have a whole process that's associated with inflammation, and cyclooxygenase enzymes are a big part of that. Cyclooxygenase enzymes are manipulated by drugs, NSAID drugs, which are like ibuprofen or naproxen, so our common over-the-counter pain medications inhibit cyclooxygenase and decrease inflammation that way. Corticosteroids, so in case you're wondering what NSAID is, it's non-steroidal anti-inflammatory drug, whereas corticosteroids are obviously steroidal anti-inflammatory drugs. So to differentiate themselves, that's where that acronym comes from. Corticosteroids block phospholipase and prevent the protein synthesis of cyclooxygenase. So it works a little bit further upstream to decrease this inflammatory process. So it does actually kind of a similar thing to what ibuprofen or naproxen does from a pain management point of view, but it's a little bit more potent and broad spectrum, and it works on a few more system. So you will see corticosteroids used for pain, especially like back pain or joint pain. We use local injections and things like that too, which we'll talk about here in a second. One thing I want to be clear on is anti-inflammatory and immunosuppressive, because they do have some overlapping, overlapping, is that what I'm trying to say? Interlocking or overlapping, combining the two here, functions, and but they are different, but they can be the same too. So the immune system isn't always necessarily going to cause overt inflammation, but it can. And so in that case, by suppressing certain aspects of the immune system, you can suppress inflammation as well, but you can also do different functions on both sides of the coin. So they aren't always connected, but they do have shared aspects. Okay, as far as the drugs go, there's a couple short-acting medications. Hydrocortisone is probably the most common one that's going to be used. That's basically a direct replacement for cortisone. Cortisone is what you can think of as, or cortisol is really what our body releases. And hydrocortisone is the drug form of that. So it's basically, they took what the body releases as a synthetic, as an endogenous steroid and made it into a drug. It's called hydrocortisone. It's got a 1-to-1 mineraloglucopotency, so it's really like what your body would release in a stress situation. Therapeutically, though, we don't use it quite as much because we don't care in a stress response as much about mineralo activity. We're much more concerned about the glucose side of things. So that's where drugs like methylprednisolone, prednisolone, they don't have prednisone on here, but that would be basically the same as prednisolone. It's prednisone is the most common oral steroid we give. And they're going to have more of a heavy focus on glucocorticoid. And then you have some of the really potent ones like dexamethasone and betamethasone, which are basically, basically 100% glucocorticoid potency. So again, not a huge role here. Sometimes we use it in septic shock in children and adults. For people who are severely septic and they aren't responding to fluids, their blood pressure is not responding to fluid boluses and vasopressor support, they might try a steroid. That's basically it. Other than that, occasionally they'll use it for niche indications, but it's not used extremely frequently in regular medicine. Prednisone, again, I said this is our go-to oral. Prednisolone is the active metabolite, so you might see certain medications like pediatric liquids come that way, but it's basically the same thing. They're used in a lot of different indications, steroid bursts, for anything from like an asthma exacerbation to chronic immunosuppressive therapy. Now, one thing to think about when you're talking about using steroids is usually when you give them in short courses, there's not a significant risk of any side effects or problems. But if you give them long-term, patients will slowly get their adrenal gland basically hypertrophies over time because you aren't using it. It's not releasing any cortisol. And so what happens to these people who are in that situation is if you pull back the steroid suddenly without tapering it off, you end up in a situation where the body can't make cortisol because it's used to not doing that. And so the body can't respond to certain stresses, environmental stresses or whatnot, and can't fight off infections potentially, which is a problem. So when you give a steroid, it's generally okay if you're going up to 2 weeks actually without having to taper. So if you're doing a 10, 14-day tape course, you can probably just cut it off. Some people want to taper anyway. But you technically don't need to, especially if you're only doing like a 5 or 7-day course. I wouldn't worry about tapering the steroid, but people will often do it just because they feel more comfortable than stopping cold turkey. But it does take some time to suppress the adrenal glands activity completely to the point where somebody would be in a situation where they don't have any activity because you've suppressed it for such a long period of time. Methylprednisolone is another one that's we covered on the chart that I just showed you. It's similar to prednisone as far as its potency goes. It's available orally, but it's probably the most common IV option. It's got a really fast onset IV, so it's sort of our go-to when anyone comes in with something acute. So if they're having an acute anaphylactic reaction, if they're having asthma exacerbation or COPD exacerbation, it's common for people to give an IV dose of this. It's, again, a popular drug choice for that. So somebody who has an asthma exacerbation might get an IV dose of methylprednisolone and then get discharged on an oral prednisone taper. Now, methylprednisolone does come as an oral medication as well. It's not as commonly used as prednisone, but it does come in this thing called the Medrol dose pack, which is a really popular thing to prescribe. This thing bugs me. I don't really understand the point of it. To be honest, I think people just think it's easy and safer when really it's not. It's a 6-day course, and it tells you when to take it. So it'll say take 2 tablets in the morning, 1 at lunch, 1 at dinner, and then 2 at bedtime. And the next day it tells you what to do. So it's got all the instructions written out on it. I think whoever came up with this is like, let's make a short taper where physicians can just, or prescribers can just write Medrol dose pack on a prescription, send it off, and it's got all the taper instructions there. Well, it's convenient, but the problem with this is that you don't really have any purpose of doing this, because you don't need to taper somebody if you're only on 6 days of steroids. You also don't need to spread out the dose throughout the day. You could take all of that at once. That's a big question we get, is like, well, somebody prescribed me a Medrol dose pack and it's 8 p.m. at night. When do I start it? You can take that entire thing at night. It's not a big deal. So why it's spread out and why it's tapered, I don't know. Again, I don't think there's a huge point in this, but you'll see these prescribed a lot. A lot of physicians and people I've worked with seem to like them for various reasons. Again, I think it's sort of a convenience thing. But you could just as easily prescribe a course of prednisone, 20 milligrams once a day for 6 days, and then stop and get basically the same effects without any adverse consequences. So again, I don't really understand the point of the dose pack, but it is there, and you'll definitely see it here and there. All right, triamcinolone is brand name Kenalog. It's probably the most popular drug choice when it comes to intra-articular injection. So when you do any type of joint injection to stop inflammation, a lot of times people who are waiting for a knee replacement and they're having issues, or have sports injuries or whatnot, and maybe waiting surgical interventions, it's a popular choice because you can get a several weeks of relief from one injection. The triamcinolone suspensions are these really kind of thick, viscous things once you reconstitute them, and they stay in the synovial space for quite a long period of time. And they don't really get any absorption systemically, so you don't have any long-term side effects with these. Triamcinolone does have some other presentations, but it's most commonly also used as a topical agent, which we'll talk about during derm. But as far as normal use, it's going to be commonly done this way when it's not used topically. So that's the big drug there. You can also give methylprednisolone, comes as a Depomedrol, which is another kind of like oily suspension type formulation, and that one can be used for the same thing. So between that one and triamcinolone, those are the ones they use for joint injections. Dexamethasone is available both PO and IV. It's a good substitute for prednisone or methylprednisolone. It's a much more potent version, and you can use relatively lower doses. So if you have to give something really large, like for cerebral edema, if people have, they'll sometimes give, especially for like traumatic spinal cord injuries, they'll give high doses of steroids at that time. And sometimes when you try and do that with methylprednisolone, you just end up with a really large amount, where it might be easier to do it with dexamethasone with the products we have available to us. It's a really popular choice for chemoimmunosuppression and antiemetic use. It doesn't interfere with plasma cortisol levels, or shouldn't, so you could still theoretically check a cortisol level on somebody and see how well the body is making the endogenous steroid. Cons, the onset's not quite as fast as IV methylprednisolone. So for those really acute situations, we're usually going to use that drug instead. Side effects for glucocorticoids are fairly extensive. Acutely, people will generally experience, the most common one probably will be psychiatric related, and people are all over the spectrum. A lot of people won't get anything at all from a glucocorticoid, but there are a fair number of people that report anything from euphoria to agitation to just feeling like depressed or overly emotional. That's really common with glucocorticoids. The higher the dose, the more likely to see that. And that's, again, definitely a acute side effect. Physical side effects would be more like long-term things. So these are terms that are historically tied to steroids. I think they're kind of weird terms, but that's what they call them. So anyway, buffalo hump is just sort of a lipid distribution issue where you get fatty distribution on the back of the neck. And then moon face, again, kind of a silly term in my opinion, but it's lipodistribution, again, issues with that, and it causes sort of a rounding of the face. Thin and bruised skin is really common, which can certainly be complicated by somebody who's on a blood thinner long term, so that's something to think about. And decreased muscle, increased abdominal fat. Again, these are going to take a long time to see these effects, but certainly going to be more common with chronic therapy. They can delay healing process and stunt growth in children, cause issues with calcium metabolism, so put people at higher risk for possible osteopenia, osteoporosis. And endocrine's probably the other one that you'll see significant complications with in the acute phase. So sometimes I've seen patients who have to go on insulin when they use a steroid burst because it increases their blood sugar so high. And it also increases appetite, which kind of compounds that problem. Okay, so Cushing's syndrome is something I wanted to touch on really briefly. It's hypercortisolemia. So you have too much cortisone going on. And usually there's some sort of a primary cause, which is likely either maybe a tumor, some area is likely going to be the cause of Cushing's syndrome. There are some drugs that I don't care you remember, but I just thought I'd mention them here. I'm not even going to talk about them because they're really odd. Symptoms most disappear after 2 to 12 months, but people will get hypertension, osteoporosis, and glucose intolerance. So just sort of like some of the things we already talked about. Addison's disease is the opposite, so it's adrenal insufficiency, and it's heavily associated with tuberculosis and autoimmune diseases. There's some other infectious disease components to it that people think are associated with it, but we don't really know why TB or other ID is associated with it. But cancer is autoimmune disease, and there's some medications that cause it too, but it's not really common. Acute, usually you're looking at fluid and electrolyte disturbances. You can replace those. You can give IV glucocorticoids. So hydrocortisone is going to be your drug of choice. Remember, it's a 1-to-1, so it's replacing the endogenous cortisone directly. A lot of patients might need additional fludrocortisone as well, which is our mineralocorticoid. That's 100% mineralo. And that's one of its major uses is for people with adrenal insufficiency, just to help with that. For some reason, supplementing hydrocortisone in patients doesn't always get them to the point where they need to be when it comes to the fluid and electrolyte issues that are caused by the mineralocyte, the lack of mineralocyte, I should say. So the fludrocortisone can help with that particular problem. Okay, quick summary. For oral options, you're basically looking at prednisone and dexamethasone. Those are the two drugs of choice you're going to have. Prednisone is going to be almost always be used for anyone who is taking a short burst of steroids or is on chronic long-term suppressive therapy. Dexamethasone's uses are more associated with things like chemotherapy, but certainly could be used for other issues. You just don't really see it commonly done for like an asthma exacerbation. IV options, methylprednisolone and dexamethasone. You might notice I didn't mention betamethasone at all. Betamethasone has some specific uses as an IM formulation for OB, and I'll talk about that. And it also has some topical applications as well, which I'll talk about in later lectures. Potency, to remember, prednisone, methylpred, and dexamethasone are more potent on the glucocorticoid side. And then fludrocortisone, the only thing I'd want you to know about it is that it's a mineralo-only product and that what generally that means, that it has more effects on the way the body processes fluids and electrolytes. Other applications about steroids, which we'll come back to shortly. The nasal sprays we'll talk about during the ENT. I call it the ENT-ish lecture because there's a bunch, it's kind of like a catch-all related to those topics. And then inhalers, we'll talk about those too. So there's some major steroid applications there, which we're going to come back to very shortly here, this module. Okay, and to finish off the immune system, we're going to talk about immunosuppressive drug therapy. So the question is, why would you suppress the immune system? And we're going to focus primarily on organ transplant today. So for both different, there's a lot of different reasons why you might suppress the immune system, but a big one why people would be on chronic immunosuppressive therapy would be for organ transplant. We'll talk about certain immunosuppressive strategies for different autoimmune diseases later in the semester, and then of course we've touched base on cancer a little bit already. So goals of therapy for transplant medicine: we want to stop the body from destroying the transplanted organ and prevent acute rejection. So host versus graft, graft versus host. Graft versus host so host versus graft is exactly what it says above when the body tries to attack a transplanted organ. Graft versus host would be like in a bone marrow transplant when the cells of the bone marrow is producing may actually cause an acute immune response against the body as a whole. So we can suppress the immune system for both ways, but we're going to focus on the solid organ transplant, so preventing host versus graft disease. Of course, an organ transplant is a significant medical procedure, so preventing acute rejection is really important, not only for the patient's health, but also to protect all the work that you just did. You took an organ from somebody that could have possibly been used in another person. You want to treat that very special as a very special gift to that person. Make sure that the person is ready for all the requirements that are coming to keep track of that, to take care of that, and take their medications appropriately. So we'll talk mostly about renal transplant, touch base briefly on cardio transplant as well. But transplant is fairly similar organ to organ. It's not hugely different. There's some different protocols and things like that, but that's about it. General strategy is you've got a few different mechanisms of action, and you're going to mix and match them until you get something that works. I scanned this out of a book. This is one of the few book-related diagrams that I really liked, and I couldn't find a great example online of it. And don't worry about this part that kind of bled off the page. It's not super important. The big stuff's over here. So I like how this looks at the CD4 T cell and shows you kind of exactly the big drug players. So we're going to talk about a lot of MMF, mycophenolate, and azathioprine, sirolimus. Here's your corticosteroids here, working cyclosporin and tacrolimus, or calcineurin inhibitors. That's going to really make the baseline of your immunosuppressive anti-rejection medication regimens. You have a calcineurin inhibitor, corticosteroid, and an antimetabolite, which is either going to be mycophenolate or azathioprine. The rest of these drugs in here have varying degrees of uses. Sirolimus, we'll talk about that, is sort of like an alternative to one of these two. But things like the MABs and OKT3 are more about preventing, if somebody is undergoing rejection, a more advanced, not advanced, but a more aggressive approach to preventing rejection, and also might be used in the immediate phase of induction before transplantation. And we'll talk about that briefly as well. Okay, so I talked about our three classes already during the diagram, but here they are: antimetabolites, calcineurin inhibitors, glucocorticoids. Somebody's going to usually be on a 3-drug regimen for solid organ transplant. It's going to consist of one of these. As I said, there's another class of drugs, which was on the previous slide, called sirolimus, which is an mTOR inhibitor. It's sort of an alternate. And there's some other agents that are more broad-spectrum immunosuppressive therapies. So antimetabolites, what they do is they inhibit synthesis of DNA. They interfere with cellular metabolism and inhibit mitosis. Azathioprine is the kind of the historical drug here. It was the gold standard for a long time, and it's still used somewhat to this day. However, mycophenolate is probably the more common one, and certainly if you're starting somebody on transplant medications, that's probably the one you're going to pick. Azathioprine would likely be used mostly for patients who have been historically maintained on it and have been doing well with it. Both medications are effective. It's just mycophenolate's generally better tolerated. Azathioprine is kind of notorious for causing GI-related side effects. In fact, it causes quite a bit of intolerance for the medication as a whole. Mycophenolate's not perfect in that aspect, but it is a little bit better tolerated overall. Hematologic, you can get leukopenia, anemias, and thrombocytopenia. So some blood monitoring may be useful in the beginning. Once somebody's stable on it, it's probably not necessary. Calcineurin inhibitors prevent the upregulation of IL-2, which inhibits activation of resting T lymphocytes. Two drugs here are cyclosporin and tacrolimus. Both of these medications are kind of interchangeable. I would say tacrolimus is probably the more common one by a good margin, but cyclosporin maybe be the older medication. Cyclosporin's undergone a few different formulations over the years it's been available. So there's a couple different brand names, and they're not technically interchangeable. So there's Gengraf, Neoral, Sandamune, and while Gengraf and Neoral are really similar, Sandamune is quite a bit different, and the bioavailability of the medications varies significantly between the different formulations and brands of it. There's a lot of generic ones out there too, and the question is the generic equivalent to Gengraf or Neoral? Again, there's kind of like the Neoral Gengraf drugs are all sort of the same, and there's the Sandamune ones, which are different. Sandamune shouldn't really be used at all. It's inferior, its absorption is bad, and it's more difficult to control the blood concentrations and keep them steady with it than it is with the other formulations. Tacrolimus is a little bit newer than cyclosporin, although it's been around quite a while. It's Prograf, and there are several different forms of it on the market. There's the regular one, which is just regular release, and that's probably the most common one you'll see. But then there's a couple different extended release formulations as well. It might be a little bit more convenient for patients. And it also comes as an IV formulation, which is nice if you have a patient who needs to be treated acutely for possible rejection, or more so likely is what you'd see as somebody who might have. But the IV tacrolimus is useful for people who need to have some boost, like maybe if they're acutely ill, like with gastroenteritis and haven't been able to take anything orally, it may be helpful for them to be able to get an IV dose of something while their illness is still ongoing. Both tacrolimus and cyclosporin are metabolized by CYP3A4, which means they're heavily affected by any drug interactions. So we have to be really careful with that. Adverse effects shared. They both cause nephrotoxicity, which is kind of interesting when you think about being used for kidney transplant. That's obviously problematic. They can cause tremor, hypertension, hyperglycemia. Cyclosporin can cause hyperlipidemia, gingival hyperplasia, hirsutism, and tacrolimus can cause some GI-related side effects and some electrolyte imbalances. Glucocorticoids, we talked about prednisone already. It's the most common steroid. We talked about the adverse effects already. I won't rehash those, but there they are. mTOR inhibitors are, mTOR stands for mammalian target of rapamycin. What they do is they inhibit T lymphocyte activation and proliferation. Two drugs in the category, with sirolimus likely to be the more commonly used one. These drugs are not used first line, but they're often used to replace calcineurin inhibitors in case of renal toxicity. So if somebody's serum creatinine is creeping up, these drugs don't really cause any renal issues, so they'll pull the calcineurin inhibitor and replace it with sirolimus or everolimus as a alternative for those. Now you can also replace the antimetabolite, but generally speaking, what's often done with antimetabolites is switching between the two when you want to find a more tolerable therapy versus dropping it altogether. However, you could do it if there was severe intolerances and keep the calcineurin inhibitor. So this is really a fourth separate mechanism, again, generally used to replace the calcineurin inhibitor, but could replace either one. Now we get into drugs that I don't care about as much. They're mostly used for induction. Induction depends on, well, first of all, what induction is basically suppressing the immune system broadly before you go into transplant to give the body the best chance at retaining that transplanted organ. It's not done universally, and some different transplant protocols might have different interpretations of how to induce or whether to induce at all. And it's going to come down to a fairly specialized system of protocols that are going to direct you towards induction or not. And that's usually going to be institution to institution. So again, I don't really care too much about these, but they're usually monoclonal antibodies. They're biologic drugs that are really expensive. And that's what I want you to know. There's some other ones too. These medications are mostly used for either on the induction side or if somebody's undergoing acute rejection that's not responding to increases in our standard medications. We might go down this pathway, but again, I don't want you to know these. If I did give you, if you did see a MAB on an exam, just know that that's likely an induction agent and nothing else. So if I was asking you for common maintenance therapies for solid organ transplant, a MAB is not going to be one of those. So just be able to recognize if you see these medications that they aren't calcineurin inhibitors, they aren't antimetabolites, and they certainly aren't steroids. All right, so let's review a little bit. Induction therapy, I just want to talk about this for a second because it is controversial and it is a part of the transplant process. But usually for induction therapy, you're looking at some kind of one of the medications we just talked about. They usually give high-dose steroids, and IV methylprednisolone is pretty common, and that's basically all you need. You're ready for transplant at that point. Once your transplant is completed, you're going to start maintenance therapy, usually within 24 hours, and monitoring the patient at determined intervals, checking blood concentrations of the drugs, making sure you're titrating appropriately, and obviously, all the surgical follow-up care that would go into that as well. If rejection is occurring during maintenance, so once you started your maintenance regimen, whether the rejection occurs immediately or whether it occurs in a year, whatever it might be, you kind of treat it based on how severe it is and based on the organ. And also, again, this might be significantly related to an institution's protocols. Likely, your transplant center is going to have a specific way that it treats rejection or approaches rejection for each patient. Kidney and liver is a little bit less aggressive than heart transplant when it comes to rejection. Labs are needed to show rejection, so some sort of, usually with kidneys, we look at creeping up serum creatinine. That's a pretty good indication that there's some possible rejection going on. Liver rejection would be looking at transaminases, ALT, AST, and seeing if those are creeping up, indicative of liver damage. We're usually going to adjust their existing maintenance regimen empirically, so increasing the calcineurin inhibitor or the antimetabolite dose. Usually the steroid dose we probably would leave alone for the time being, unless they wanted to do like a short burst of steroids or give maybe some IV steroids to suppress the immune system more aggressively. If the labs are unresolved after this, then we move on to where a heart transplant algorithm would start. And heart transplants usually will look at biopsying right away if they're suspecting rejection. And that would be what we do with kidney and liver at this point. Biopsy, confirm rejection, classify the rejection, which again, I don't know how they do that. I'm not going to get into it. And then usually we're treating fairly broadly with IV steroids. If that doesn't work, we're going to move to a more aggressive platform, which is treating with some of the other drugs we talked about. You could supplement the maintenance regimen with IV versions of it. So IV tacrolimus, mycophenolate also comes IV. If rejection is still occurring, that's where we go to the really big broad spectrum stuff and say, okay, let's wipe out the immune system for temporary. It's sort of like a reset button from a pharmacologic perspective. One thing I'll just say about rejection and induction and all this stuff, and while it's important to kind of understand the whole picture and what we do when these drugs fail, the more important piece is making sure that the drugs don't fail and that patients are taking them. So compliance is really significant. If the patient's not adherent with the medications, this is the path they're going to go down. It's expensive and it can put their life at risk as well. So we want to make sure that the patient is taking their medications appropriately, that they're competent to do this or they have help to do this if they need it. And that's usually done in the pre-transplant process, but still something worth mentioning. So it leads me into my point. I mean, compliance is huge. Patients who are have a history of medication non-adherence aren't transplant candidates. They won't get on a list of a transplant. No center would put them on a list if they have compliance issues. Medications are usually pretty expensive, so there are some costs associated with it. Insurance pays for most of them, whether it's state insurance or private insurance. It's likely covered, but still there's some cost. There's consistent timing to consider. We're a little bit more stringent on timing when it comes to transplant meds and other meds. Other meds, if you're on a blood pressure med, that's twice a day. If you take it at 6 one day and 6 a.m. and then 8 p.m. and the next day you do it at 10 a.m. and then 6 p.m. You kind of do a little willy-nilly that way. It probably doesn't make a big difference. But if it's a transplant med, that can cause dips in your serum concentration. So it's really important to take it like 8 and 8 if you're twice a day, every day. So that's getting the most consistent blood concentrations possible. It gives your body the best chance at not rejecting that organ. You might have other drugs to prevent adverse drug reactions. So things like opportunistic infections are common with people on chronic immunosuppressive regimens. Mouth ulcerations, thrush, skin infections, malignancies, skin cancers can prop up to osteoporosis. So Things like nystatin, which is a topical antifungal that you can use as a mouthwash, can be helpful. Sometimes you might have a chronic or temporary courses of antibiotics to suppress certain infections. Calcium and vitamin D to prevent osteoporosis. We'll talk about that later during that lecture. But the point is there might be some things you add on simply to counteract the problems you're going to cause by giving somebody chronic immunosuppressive therapy. And that doesn't even touch the steroids, really. We didn't talk about those. So chronic steroid use, obviously, you've got osteoporosis, you've got diabetes risk, you've got possible mental health related things too that could crop up. Frequent monitoring follow-ups required. And again, there's a lot of protocols for how to start people, how frequently you test, how you deal with rejection for patients. So for this lecture, I really want you to focus on the three major classes of medications used to suppress the immune system for solid organ transplants. So your calcineurin inhibitors, your antimetabolites, and your corticosteroids. And the other ones just kind of have an idea of how they're used, but as far as memorizing their names and everything, you'll be just fine if you can recognize which ones aren't calcineurin inhibitors, antimetabolites, or steroids.